This is the second part of our lecture series on digestive system. Let's now take a look at an overview of chemical digestion. There are four major categories of biological macromolecules: proteins, carbohydrates, nucleic acids, and lipids. And these are large molecules necessary for life that are built from smaller organic molecules. Three of these four macromolecules, namely carbohydrate, protein, and lipids, are broken down into their respective constituent monomers. And this is so that they become small enough to be absorbed into either the bloodstream or into lymphatic vessels. Nucleic acid, the last category, this is a class of macromolecules that are not utilized by the body. Instead, they are digested, catabolized, and then eventually excreted by our body. So chemical digestion is a term used to refer to the process of breaking down these larger macromolecules and breaking down the chemical bonds within these larger macromolecules with the aid of chemicals, that is acids and enzymes. So using acids and enzymes to break larger molecules into smaller molecules. And this is different from mechanical breakdown, because where mechanical breakdown involves simply larger chunks of food into smaller chunks. We're not actually breaking down, we're not actually breaking chemical bonds, but chemical digestion actually involves breaking of those chemical bonds. Okay, and here is what you have to know about the detailed steps. Okay, so we can see carbohydrate here exists as a polysaccharide. Poly is multiple, saccharides referring to sugar. Example of this is starch. Starch is the general form of carbohydrate that our body is actually capable of digesting. Unlike cellulose, which is the polysaccharide produced by plants, we can ingest those, but our body doesn't have the chemicals or the enzymes for breaking down cellulose. That's why cellulose actually passes through our bowel and then comes out as a species. And so back to this polysaccharide in the form of starch is acted upon by salivary and pancreatic amylase. So we have amylase to break polysaccharide down into disaccharides, which consist of two monomers linked together. And then different disaccharidases, or the enzymes for breaking down these disaccharides, then act on these disaccharides. Okay, so sucrose gets acted on by sucrase. Maltase acts on maltose. Lactase acts on lactose to break down these further into monosaccharides, so single polymers. Okay, you are not responsible for memorizing, for example, sucrose is broken down into fructose and glucose, maltose into 2-glucose, lactose into glucose and galactose. So you don't have to know that, but you should recognize these names as names of enzymes that break down disaccharides. And then this amylase as an enzyme that breaks down polysaccharide into disaccharides. Okay. Now, in terms of protein digestion, okay, you can see here, proteins are made up of amino acids linked together and then folded, right? And then, so our stomach produces pepsin, which is the enzyme that helps take apart large proteins into polypeptides. Okay, and the large polypeptides are then acted on by the pancreatic enzymes, namely trypsin, chymotrypsin, carboxypeptidase. These are all enzymes that act on large polypeptides. Okay, and then once this is broken down into smaller polypeptides, then we have yet other enzymes, aminopeptidase, carboxypeptidase, dipeptidase, that further break these down into single monomers in the form of amino acids. Okay, so you should be able to recognize all these as protein digestion enzymes. You don't have to know which specific peptide bonds each of these enzymes work on. Okay. As for lipid digestion, okay, large blob of an emulsified lipid is taken apart using bile, and recognize that bile is not an enzyme. We have a video later in this lecture that explains very well how bile acts on larger blobs of lipids, and then forming emulsified lipid, which are smaller chunks that allow lipase to then act on to further actually chemically break down individual triglyceride molecules into its constituent, meaning monoglycerides and fatty acids. These are then absorbed. Okay, so these are the forms that are absorbed in our body. Moving on to taking a closer look at our stomach. Our stomach has multiple functions, one of which is to store food. It also allows for mechanical breakdown of food chunks into a slurry called chyme. Because of secretion of hydrochloric acid, it's able to initiate a process of protein digestion, specifically in the process of protein denaturation. Okay. So protein denaturation is basically unfolding the protein by breaking the hydrogen bonds. Hydrogen bonds are non-covalent bonds. Okay. So they are weaker bonds, but the hydrochloric acid helps break those weaker bonds to unfold the protein. And once this protein is unfolded, the pepsin is then able to access the polypeptide chain and more easily cut it up into pieces. Okay. Even though the majority of nutrient absorption happens in the small intestine, your stomach is also capable of absorbing a very limited number of substances, usually the lipid-soluble substances, such as alcohol and aspirin, even though more aspirin is actually absorbed in the small intestine. And also meter delivery of chyme into duodenum. This means the stomach, through its pyloric sphincter, helps regulate the speed at which the chyme enters into duodenum, and this prevents overwhelming the duodenum because we have to regulate the speed so as to match it with duodenum's absorptive capability. Okay, its ability to absorb things is limited at a certain rate. And finally, stomach is responsible for secretion of intrinsic factor. This intrinsic factor has an important role in the absorption of vitamin B12 or cobalamin in our small intestine. And in patients whose stomach fails to produce or utilize intrinsic factor, it can actually result in a condition called pernicious anemia, which is a form of anemia. Okay, because cobalamin or vitamin B12 is essential for cell division and for cell cycles, and without which your cells, including red blood cells, will be unable to divide and create more cells, thereby leading to anemia. And here's just some GIF or animation showing the mechanical breakdown motion of your stomach. Now, a quick review of the gross anatomy of our stomach. Our stomach, you could see superiorly, we have the gastroesophageal sphincter, also known as lower esophageal sphincter, around here, that divides esophagus from our stomach. And the stomach itself can be divided into a few regions. the gastric cardia, gastric fundus, gastric body, and the gastric pylorus, which includes the pyloric antrum and the pyloric canal. And we also have a valve or a sphincter, pyloric sphincter, that separates our stomach from the duodenum. And this sphincter functions to regulate the speed at which stomach contents or the chyme is being emptied into duodenum. Okay. And we need it to be slow enough such that our duodenum has time to extract the most nutrients to be absorbed from that chyme. And most important to note here is that the muscularis externa in our stomach, unlike the rest of our digestive tract, which generally just have 2 layers of muscle, here we have 3. Okay, in addition to a longitudinal layer, a circular layer, we also have an oblique layer. So these muscles, with their fibers oriented in different directions, allows the stomach to churn with more force and in more directions, allowing for a stronger power for mechanical breakdown of the food. And mixing that with acid, and that becomes our chyme. Looking at the microanatomy of our stomach, we see that it's composed of simple columnar epithelium dotted with gastric pits. Okay, that then lead into the gastric glands, which have secretory functions. So the surface epithelium is composed almost entirely of mucus cells, and these mucus cells secrete a thick, viscous, insoluble, and alkaline mucus filled with bicarbonate ions. And that has a protective role. It prevents those chemicals like pepsin and hydrochloric acid from damaging the stomach itself. Okay, so in other words, stomach, it's made of mostly proteins, right? It's like the rest of our body, lots of proteins. So we want to be able to secrete a chemical that's capable of digesting and breaking apart proteins, but we don't want the organ that secretes it itself to be digested. Okay, so these mucus cells are able to produce a thick mucus that prevents the stomach itself from being damaged. And then in terms of the secretory cells, okay, down here, okay, and by the way, mucus neck cells, we don't know the function of these, so I've graded out. Okay, so these secretory cells down here are the cells that are capable of producing gastric juice, which is hydrochloric acid with different enzymes. So the hydrochloric acids are secreted by our parietal cells over here. Parietal cells also secrete intrinsic factor that's important for vitamin B12 absorption in the small intestine. The hydrochloric acid secreted by parietal cells helps create a low pH environment, in other words, an acidic environment that's important for the activation of pepsin. So pepsins are actually secreted by chief cells in the form of pepsinogen, which is a precursor of pepsin. It's not yet active. Okay, and the activation of pepsinogen in turning into pepsin requires the acidity of that hydrochloric acid, as well as the presence of pepsin itself. So pepsin itself helps activate more pepsin. In other words, helps turn more pepsinogen into the active pepsin. Okay. So the hydrochloric acid, in addition to contributing to protein denaturation or unfolding of the proteins, it also helps with breaking down plant cell walls, okay, and also killing many bacteria that enters this part of your digestive tract. Chief cells, as we mentioned, secretes pepsinogen, which are later activated into pepsin by the hydrochloric acid and the pepsin itself. These Ch cells also secrete lipase. So lipase secreted by these Ch cells in your stomach are called gastric lipase because they're secreted by the gastric region or the stomach. And they only account for about 15% of the fat digestion in your entire GI tract. So not a whole lot, but it is a significant site of digestion, even though most of it happens later in our small intestine. Finally, we have these enteroendocrine cells. So enteral is referring to your bowels, and endocrine, well, endocrine molecules travel in blood, right, or hormones. And so these enteroendocrine cells are really a collective term for a number of different types of cells that secrete hormones and paracrines. They include cells like G cells for secreting gastrin, D cells for secreting somatostatin, enterochromaffin cells or ECL cells that secrete histamine, which we'll see in the next slide. So this is a summary table that looks at the different types of cells we just discussed. Okay, and their respective secretion, as well as the function of their secretion. Okay. As we previously mentioned, our stomach has to have several methods of protecting itself, forming a protective barrier. Otherwise, it would be digested by its own secretion, namely hydrochloric acid and the protein digesting enzymes like pepsin. So the mucosal barrier is created by three major factors. First of all, we've got that thick coat of alkalinic bicarbonate-rich mucus. So this provides a physical barrier. Bicarbonate is useful for neutralizing acids like hydrochloric acid, and also serves as a really effective buffer, like acid-base buffer, okay? And epithelial cells of gastric mucosa are also joined by tight junctions that prevents gastric acid from leaking into the underlying tissue. And finally, the damaged epithelial mucosal cells are quickly shed and replaced. So there's a pretty high turnover rate of about 3 to 6 days. Please pause our lecture and take a look at this video. The regulation of gastric secretions can be roughly divided into 3 phases: cephalic phase, gastric phase, and the intestinal phase. The first phase, cephalic phase, begins before the food even enters into the stomach. So it can be triggered by anything from the sight of food, from the smell or the taste, or even just the thought of food. These inputs are related to your hypothalamus, which then triggers the medulla oblongata on its vagal nuclei. The vagal nerves carrying its parasympathetic fibers then relay the signal to your stomach to promote the stomach secretion of gastric acid. Okay, and moving on to the gastric phase. The gastric phase, its most important triggers are gastric wall distension from food entering into stomach, and also so this is considered more of a neural mechanism, right? Because the stretch receptor then activates neural reflexes, which then promotes secretion by the stomach. But what's an even greater contributor or greater factor to promoting the secretory function of stomach is the hormonal influence. And this comes in the form of food chemicals, especially peptides and caffeine, as well as the elevation in pH, okay, from the food particles. Okay, the food particles now mixed with hydrochloric acid brings up the pH of our stomach, and that triggers chemoreceptors in our stomach, which then stimulate G cells to produce gastrin. And gastrin is a hormone that, when released into blood, it then acts on our stomach, promoting the secretion of hydrochloric acid. Okay, and then the hydrochloric acid, as we mentioned, can then start to denature a protein, to unfold the protein. So during this phase, gastric phase, as we mentioned, gastrin is much more important factor in the secretion of gastric juice than the neural influences. And finally, moving on to the intestinal phase. This phase is triggered by when partially digested food, the kind, begin to empty from the stomach into the duodenum. And this filling of the duodenum stimulates the intestinal mucosal cells to then release intestinal gastrin, or enteric gastrin. Okay. And what this does is that this enteric gastrin briefly stimulate the gastric glands to continue their secretory activity briefly. But as more food then enters into the small intestine, we see an initiation in what's known as the enterogastric reflex, which prohibits or inhibits further gastric secretion and food entry into duodenum. And this prevents the small intestine's absorption capability from being overwhelmed. Okay. In addition, enterogastrones, such as secretin and CCK, are chemicals that inhibit gastric activity, okay, triggered upon duodenal distension, as well as the presence of food with high fat content or high acidity. So some of the general concepts to note is that you'll see that most food-related stimuli that happen in the head, like the thoughts of food, visual stimulation, smell, sight, sound, those happening in the head, as well as food-related stimuli happening on the stomach, will act to promote gastric secretion for the stomach to increase its production of hydrochloric acid and gastrin. And whereas most stimuli that act on the small intestine will trigger the enterogastric reflex and the release of secretin and CCK, both of which will then act to inhibit further gastric secretory activity. Okay, because as you can imagine, once the food has entered into the duodenum, okay, we now have to worry about our small intestine being able to extract the most nutrients out of that content. So we don't want to empty the stomach into the duodenum at too fast of a rate. We want to slow it down. And so we're going to now try to lower the stomach secretory activity. In this slide, we take a look at the cells that are important for the regulation of gastric contractions. As we've previously learned, your stomach contains 3 layers of smooth muscle. So this is all of smooth muscle cells. Okay, and this is the serosal layer, visceral peritoneum. Okay, and you'll see that in between this longitudinal layer of smooth muscle and the circular layer of smooth muscle, lying in between the 2 layers of smooth muscles, is our myenteric plexus, also known as Auerbach plexus or myenteric plexus of Auerbach. And this is a group of ganglia, in other words, neuronal cell bodies outside of the central nervous system, so in the peripheral nervous system, that run throughout our entire gastrointestinal tract and innervates multiple layers of smooth muscles. Okay, And interspersed between the mesenteric plexus cells of Arbach, we also see these ICC cells, that stands for interstitial cells of Cajal. These cells are known as the enteric pacemakers. So if you think about the pacemakers of your heart, that sets the rate and rhythm at which your heart contracts at. Enteric pacemaker cells have similar function. They are modified non-contractile smooth muscle cells located within the mesenteric plexus. Okay, once again, in between the longitudinal layer as well as the circular layer of the smooth muscle. And these cells, the interstitial cells of Cajal, sets the contractile rhythm of stomach by its spontaneous depolarization and repolarization. And that establishes a cyclic pattern of slow waves, which then triggers a cycle of smooth muscle contractions and relaxations of your stomach to then take place. We're moving on to talking about the liver. Your liver is the largest gland in your body, and it performs over 500 functions. And we'll only be concerned with a few. Okay. And so your liver is capable of storage of glycogen, which is a polymer of sugar. Okay, so if you link up a bunch of these monosaccharide molecules, you'll get a polysaccharide, okay, or a polymer of sugar called glycogen. So in the human body, glycogen is the form that we store carbohydrate as, whereas in plants store sugar in the form of starch and cellulose. Your liver, furthermore, is also capable of storage of vitamins, especially the fat-soluble vitamins, namely vitamin A, D, E, and K. Okay. It's also capable of storage of minerals such as iron. Furthermore, your liver is capable of synthesis of a lot of the plasma proteins, including many of the coagulation factors and an important protein called albumin, which helps regulate osmotic pressure inside our blood. Detoxification is another important function of the liver. Many of the medications that you take undergo metabolism inside the liver. So if there wasn't a liver to metabolize, you would quickly reach a toxic level with many of these medications. And similarly, for this reason, patients who are undergoing liver failure, the toxins, because they are not able to be removed from the blood, they can quickly start to impair a person's brain and other organs when those toxins are distributed through the general circulation. Liver is also capable of enzymatic activation, as well as metabolism of everything from fats, proteins, carbohydrates, alcohol, drugs. Okay, and furthermore, liver is capable of turning ammonia into urea in protein metabolism pathway. And finally, our liver is capable of bioproduction. So even though bile is stored inside our gallbladder, it's actually synthesized by the liver. Please pause our video and take a look at this YouTube. This is a YouTube about bile. Bile is a very important chemical for fat digestion within our small intestine. It's really a mixture of different constituents, including bile salts, which is a cholesterol derivative that functions in the emulsification process of fat. Bilirubin is a byproduct from the breakdown of red blood cells and the heme component coming from the red blood cells. So the heme component is metabolized, okay, and into bilirubin, and bacteria then can further break this down into stercobilin within our intestine. And this is what confers that brownish color to your feces. Your bile also consists of other things like cholesterol, triglyceride, phospholipid, and electrolyte. Here we can see that this is a large fat globule with multiple individual fat droplets. And so what bile salt does, you can see that bile salt has this property of having a hydrophilic end and a hydrophobic end. So having these two different ends allows it to act as an emulsifying agent, okay, such that its hydrophilic end will face the water, the aqueous solution, whereas its hydrophobic end, or the lipid loving end, lipophilic end, will then face the fat, okay? And in this way, it's able to break down that fat globule into individual fat droplets, separating that fat globule into small fat droplets that the lipase can then act on to further break it down into monoglycerides and fatty acid chains. So bile is produced continuously within your liver and then stored and concentrated in a gallbladder. So you may understand why gallbladder can be removed and the person can live on just fine, but you probably never heard of someone living without their liver. And liver, as we've mentioned, performs 500 plus functions, only one of which is creation of or synthesis of bile. So in patients who've had their gallbladder removed, okay, even though their liver is still capable of synthesizing bile, but because they aren't able to store large amounts of bile, so when they eat a fatty meal, okay, their liver isn't going to be able to quickly secrete all of that bile to emulsify the fat. And so for that reason, patients without their gallbladder or who've had their gallbladder removed, if they eat a fatty meal, they would just experience diarrhea. All that fat would just pass through their GI tract unabsorbed, okay, and so it will end up in your feces. After a typical person eats after a meal, bile is released into duodenum to emulsify fat. And so your gallbladder can actually release more or less bile depending on the fat content of your meal, okay? And this allows fat and water to then mix and permitting the digestive enzymes in the water to then digest the fat. So some of the symptoms in liver disease, okay, reflects the functions of our liver, and that includes jaundice, okay, ammonia in blood, hypoglycemia, okay, bleeding, as well as intoxication. Here's a great video going over the concept of fat emulsification. Please take a look at this. Moving on to gallbladder. The primary function of gallbladder is just to store and to concentrate bile after that bile has been synthesized by the liver. Okay, and so once there are fatty fluid entering into your duodenum, your body senses that and releases bile via the cystic duct. The bile then is released into the common bile duct, CBD, and then eventually into the duodenum. Cholelithiasis or gallstones is where there's an obstruction of bile from gallbladder due to the gallstone. And it can be very painful when the gallbladder contracts against an obstructing stone. And there are many different risk factors to this. It can be caused by too much cholesterol in blood, or it can be too few bile salts. And the commonly known 4F risk factors are female, so female at higher risk than male, fat, so especially obese patients, fertile, so patients who are pregnant, 40, Okay, basically patients in mid-age. Okay, obstructive jaundice is a commonly seen symptom for patients in with cholelithiasis or gallstones, and this happens when the blockage causes bile salts and pigments to accumulate within blood, and that results in a jaundiced look on the skin as well as on their mucosa. There are multiple different types of treatments possible, and there's crystal dissolving drugs that patients take orally. There's ultrasound vibrations called lithotripsy that can actually work to treat the patient without having to cut into the patient. There is laser vaporization. There is cholecystectomy, which involves removal of their gallbladder. So this is a quick video on cholelithiasis or gallstone. So take a look at it. Let's now take a look at our pancreas. Pancreas is a very special organ because it's got a combination of exocrine and as well as endocrine functions. The exocrine pancreas is responsible for secreting the pancreatic juice, and that's released into our small intestine. And pancreatic juice is a watery alkaline solution with a pH around 8 that is great for neutralizing the acidic chyme entering from stomach into duodenum. Pancreatic juice also contains a different electrolyte, mostly the alkalinic bicarbonate. There are also multiple important enzymes that carry an indispensable role in digestion within our duodenum, and that includes enzymes for digesting all food categories, including proteases for digesting proteins, amylase for breaking down carbohydrate, lipase for breaking down lipids, nucleases for actually breaking down nucleic acids. And so the proteases are actually secreted in inactive form, which we call zymogen, and that prevents these enzymes from digesting the organ itself. And these are then later cleaved and become active within the small intestine. So what secretes all this enzymes, alkalinic juice, in other words, the pancreatic juice, are two different types of cells. These are the acinine cells that secrete the digestive enzymes. And we also have the duct cells, which secrete most of the alkalinic juice. Now, the endocrine portion of pancreas are the pancreatic islets or islets of Langerhans. And these are microscopic mini endocrine glands that are scattered throughout the entire pancreas. And they're interspersed with these SNR cells and duct cells. But instead of dumping their secretion into ducts, these islets actually release their secretion into blood, which is why they are known as the endocrine pancreas. Okay, because what they secrete are hormones that travel through blood. And there are alpha cells in these islets that secrete glucagon, which is a hormone that promotes elevation of glucose in our blood. Okay, so it's a hyperglycemic hormone. There are also beta cells within these pancreatic islets that secrete insulin, which is a hypoglycemic hormone. So it helps promote the cellular uptake of glucose from blood and thereby lowering glucose level within your blood. There are also other cells within this islet that we won't discuss in this class. Okay. So we've already discussed most things on this slide. I just want to mention once again, zymogen is an inactive precursor of an enzyme. So it's a general term referring to these inactive precursors of enzymes that are secreted by your pancreas. So these zymogens, they require a biochemical change, such as a hydrolytic reaction that cleaves the original precursor enzyme, proenzyme, revealing the active site. Or it may involve changing the configuration to reveal an active site for these to then become an active enzyme within the small intestine. Okay, and this is something we mentioned already as well, endocrine function of pancreas. The alpha cells secrete glucagon, beta cells secrete insulin. We also have delta cells that secrete somatostatin. And so glucagon, as we mentioned, is a potent hyperglycemic agent, meaning it works to raise your glucose level in your blood. And its secretion is triggered by a drop in your blood glucose and an increase in your sympathetic activity. Okay, and this should make sense because when you're in a fight or flight situation, right, your body is going to work to mobilize energy. And so you'll want to have more glucose in your body to supply the vital organs, like especially your brain, skeletal muscles, your heart. Okay, so in those cases, glucagon, you would want more glucagon to trigger more glucose floating around your blood. And glucagon release is inhibited by insulin, somatostatin, as well as elevation of glucose in your blood. The effects of glucagon is these different metabolic processes that all work to raise your blood glucose, including glycogenolysis, which is breaking down of glycogen. Glycogen is a polymer of monosaccharides. So when you break down glycogen, you will yield glucose. Okay, so increasing glycogenolysis, especially in your liver, will help release more glucose into your blood. Gluconeogenesis is synthesizing glucose, again, helping to mobilize energy to supply your organs for that state of crisis. Lipolysis is breaking down of fat, and converting fat also helps mobilize, utilize fat as a form of energy to support your body through that crisis. And the insulin is hormones released by our beta cells of our pancreas, and it has opposing effects to glucagon. Its secretion is triggered by hyperglycemia, and it's inhibited by somatostatin and hypoglycemia. So think of insulin as a hormone that acts to promote cellular uptake of glucose, to store that glucose for later use. And so it's going to bring down the blood glucose level. Insulin acts to increase glucose transport into skeletal muscle and adipose tissue. Here we've got an illustration showing that when insulin binds to cell receptor, it induces exocytosis of these glucose uptake transporters. And these are then moved into the membrane, allowing more glucose to be uptaken into the cell. Okay. Insulin also promotes glycogen synthesis and storage. So once those glucose enters into the cell, they can then be linked up and to synthesize the form of glucose that we store in our body, which is glycogen. Okay, and here promotion of protein and triglyceride synthesis goes along with the concept of insulin promoting storage of our energy for later use. Okay, and insulin also decreases glycogenolysis, so we want to break down less glycogen. Okay, because breaking down glycogen will be mobilization of that stored glucose for use, and we don't want that. Gluconeogenesis is also reduced under the influence of insulin. Let's now take a look at a very common condition called diabetes mellitus that's related to our discussion on pancreas. Take a moment to view this video discussing diabetes mellitus. Now, there are two general types of diabetes mellitus. Both types have similar symptoms: polyuria, polydipsia, polyphagia. Polyuria is excessive urination. Polydipsia is excessive thirst. Polyphagia is excessive hunger. Okay. Type 1 diabetes mellitus, sometimes abbreviated T1DM, sometimes called juvenile diabetes, is due to insulin insufficiency. Okay, and it's an autoimmune disease that develops when your body's immune system attacks your own pancreatic beta cells. And these are the only cells in our body that makes the hormone insulin. And so type 1 diabetic patients must pretty early on in their disease, they become insulin dependent. They need insulin every day, either by injection or by pump. Okay. And even though these patients without treatment, their blood glucose is very high, but these patients, their tissue cells are actually undergoing starvation because the cells are not able to take up the glucose and use that glucose floating around your blood for energy. And so their cells are starving despite the high glucose. And over time, the high glucose level in your blood can also cause end organ damage, so damage to your different organs. Okay. Type 1 diabetes mellitus accounts for generally only 5% of all diagnosed cases of diabetes in adults. Even though it's often diagnosed in children and young adults, we've seen in more recent decades that this disease can actually occur at any age. We don't have currently we haven't found a way to prevent type 1 diabetes from happening. Type 2 diabetes, formerly called adult onset diabetes, unlike type 1 diabetes, is actually due to insulin resistance. So these patients, early in their disease, their pancreas actually try to compensate for the tissue resistance to insulin by secretion of more insulin. So because their tissues aren't responding to insulin, that's the insulin resistance. So their pancreas actually ramp up the production of insulin to try to compensate for that resistance at the tissue level. But eventually, their pancreas work harder and harder, and they eventually start to give out. Okay, and so these patients can eventually, later in their disease, progress to become insulin insufficient, meaning they can, at this stage, they would start to require insulin injection. Okay, and so type 2 diabetes accounts for the majority of all diagnosed cases of diabetes in adults, generally associated with risk factors like older age, obesity, family history of diabetes, history of gestational diabetes, impaired glucose metabolism. There's also a race ethnicity factor in this, as well as physical inactivity. Okay, and even though it's still rare, but in the recent decades, we've seen more and more type 2 diabetes being diagnosed in children and adolescents, especially those who have those above mentioned risk factors.